So it's my honor to be sitting along with Dr. Adarsh Chowdhary, whom I came to know in the year 1999 when I was doing my residency. During that time, we would hear that who's the person who's doing a pancreatic surgery. The only one name which could come was Dr. Adarsh Chowdhary. Then in 2004, I happened to attend the GI cancer program in Mumbai, which was organized by Leelavati, where every question would come and Dr. Adarsh Chowdhary would get up. And I would say this person is so young and how come he is so much knowledgeable and he is full of energy where all the old people who are giving the lectures and giving their talks, so they have no answers to his question. At the end of the session, one line which he said was, I still remember that very clearly, he said, what I could conclude from this talk today is that oncology helps the oncologist. So I don't know how far that is true now, but then yes, to some extent in GA surgery, this is very, very important that most of the surgery cancers are amenable only to surgery. So welcome, sir. And since it is going to be an interactive session, we thought the doctors of Abhrisa should gain from his vast area of expertise and knowledge. So, sir, if briefly you could tell us about your journey from where you started and...
I thought this is an interactive session. I did my MBBS from Medical College Simla, then I was in PGI, then I was in Gangaram, and now I'm in Medanta Medicity. So I generally believe that these sessions should be more talking about the content rather than my association. You know, once Deepak Chopra, the famous motivational speaker, you all know him, he was asked in an interview that how do you feel when you interact with people like Roger Federer, Michael Jackson, and Hollywood stars? He said, I feel very sad when you talk of my association and not my content. So we should talk of the content, what we can talk, what we can do, because I believe medical training and teaching is at a very sad state of affairs in this country. We are passing through a very bad phase. And I was thinking, like, you have such a great session today, and if you see in the audience, there are no medical students. It is so sad that there is such a great organization done, but there is no audience to learn. So something definitely is missing in the way we are conducting ourselves. So I think that's what's very sad for me.
Yes, sir. If you can guide us, or you can share. If you can just share your experience over the years, like over last 20-25 years, how the doctors have changed and how the patients have changed and how the art of surgery has changed.
It's a big question, but I may not necessarily answer in that order. The first thing is, I think there's a drastic change in patients' expectations and understanding. When I was in PGI Chandigarh, patients will never demand anything. Any complication can occur, anything can happen. There's a great degree of acceptance, and there was a great belief in the doctors and the surgeons. Patients will never question. In the last couple of years, patients have become very demanding. It's very good, and it's not so good either. Patients should be aware of their rights, which makes sense, but their expectations have gone very high and sometimes to an unbelievable expectation. I believe the fault lies within us, because I believe we have not been able to, we are not trained. You see, medical training, there is no class in how to communicate. We have never been told how to convey bad news. We've never been told how to discuss the results of surgery. When I discuss with a patient for a pancreatic duodenectomy, should I tell a patient that there is a 10% chance of a complication, or should I tell that 1 in 10 patients will develop a complication? These two have very different connotations for a patient. So patients' expectations have changed. There is more access to information. They understand things better, and they also know that their rights are getting better and they are more litigious than they were ever. I never heard a complaint against my teachers or a medical legal a case against a medical one of my teachers. But when I was in Gangaram Hospital, there was a case against me for the first time. I felt very sad. I went to my colleague. I said, "There's a case against me." He said, "Welcome to the club. You become a famous surgeon," because that's what happens. So that's regarding the patients. Your second question was, how have surgeons changed? I believe surgeons of today are very fortunate because knowledge is available at doorstep. Today we need experts to analyze knowledge, not to get knowledge. When I was in PGI, I sometimes had to check an article. I had to take a bus from Chandigarh to Delhi at night, go to the National Medical Library. Go to the library, there were heaps of journals. You search a journal lying in a lot of dust. You finally reach that journal, you open it, and the pages you want were torn off by somebody. You come all the distance, and still you could not get information. Today, information is available on the net. Everything is available on the net. What we need today is the ability to analyze that information, and unfortunately, we have not learned. We need to be taught how to differentiate science from pseudoscience. My biggest problem is when we talk here, we always talk of successes. We always told, I did this procedure, this went well. We never talk of numerators and denominators. In life, you learn more by asking questions, not by getting answers. When I see a workshop, a complication is occurring, bleeding is occurring, people are walking out and ask, what happened? This is all nonsense, some bleeding is going on. That's when you need to sit down and see, how does this person stop that bleeding? The problem with us is that we want to see life black and white, whereas surgery, medicine, life is not black and white, it is gray. Most mistakes occur because we assume answers. We as physicians should learn to live in ambiguity. I do 100 pancreatic resections every year. I do not understand why is it that my best anastomosis leak and my worst anastomosis get well. So there are definitely factors that which we do not understand. To me, the best surgeon is one who says, I don't know. If you assume answers, we recently had an interview for a senior resident in our department. I asked one person, what is the surgery that you can do? He said, I can do everything. You give me any surgery, I can do everything, I'm an expert. So I told him, you've come to the wrong place. We are not that good. We want somebody who's able to learn. Intelligence comes not from reading. It comes from curiosity. Once you cultivate curiosity, that's what we need. I'm sorry if I sound like idealism, but I think it makes sense, because if you're curious, you learn much more. Have I answered your question?
Yeah, sort of.
Good afternoon, sir. I'm a big fan. I've been following your work for several years, and I really enjoy your communication of things scientific and non-scientific. I learned a lot from you over the years. So I have two aspects to a question. So when we were residents, I think we heard our senior professors talk about the good old days and how residents were terrible and how we would never match up to their expectations. Now I'm very mindful that we are at a stage where we are considered to be senior, although I don't feel that old, but it is, and so is it simply a generational thing where seniors always felt that things were better before and things are getting worse now? Are we going through a generational, is it our problem rather than a resident's problem? That is probably the first question. The second question is that if you were designing a curriculum today for MBBS students, I completely agree with the fact that the challenges are unprecedented. We have a much to change. How would you change the curriculum?
I allow both of your questions. I think we are poor role models. We are not great teachers as our teachers were. Our teachers were iconic. They had great values. We respect them. They changed our lives. I think somewhere in between, we've lost the way. I may be wrong. There are so many things which I can discuss. I think we are at also fault. We have become, possibly we are taking ourselves too seriously than our profession too seriously. Why don't you sit down? So I believe that's the first question. We are equally responsible than blaming our juniors. We have to become a role model. Your second question is very relevant. Our medical curriculum is outdated. In Indian system, we emphasize memory, regurgitation of data. What are the causes of pain in the right iliac fossa? So people have a mnemonic, this, enumerate, right? And an examiner wants to listen and answer which he wants to listen. I've been an examiner for many years. To me, an examination looks like an interrogation system, as if you interrogate a thief. What are the 7 causes? What are the 9 causes? That's not how you manage patients. If I had to design a curriculum, I'll make it problem-oriented. What do you do when a patient comes to you? The living example is this: majority of classes, the toppers never did well because they were merely regurgitators. They had memory, and I remember when my teacher used to teach some of them, they used to emphasize, take my notes. My notes are the truth, whereas books are the gospel truth. So we always emphasized memory. We suppressed curiosity. As an examiner, as a senior, it is not important to give the right answer. It's important to see how a candidate thinks. Am I right? If your process is right, sometimes your results may be wrong. We should emphasize processes. Am I right? That a protocol has to be followed. If you follow protocols, if we emphasize systems rather than memory, that is the communication system I'd like to change.
I'm just going to ask one follow-up question for surgery. So when we were training, we had access to a vast number of patients and we had a learning curve which we supplanted. Now, of course, the number of patients has changed because the ratio has changed, and equally the expectation for complications is much lower. So what can we do to make sure that surgeons who are currently in training get the same level of training as compared to, can we learn from, say, other disciplines like pilot training, for example? How can we de-risk this?
That's a very good question. Unfortunately for surgeons, we believe we've reduced surgery to a circus. We believe surgery is a technical exercise. I feel very sad when you go to workshops and somebody just shows a video of somebody has started doing a fundoplication or the liver resection. We have never shown the preoperative reports. We have never shown the CT scan. You tell me yourself today, liver surgery is changed because of radiology. How many times we discuss radiology before surgery, that this is the plane I will go, these are the things I will do. So we have to change the whole thinking that surgery has a great cerebral dimension to it. When I went to PGI, I was told that you will never become a good surgeon because there is not much cutting given in PGI. But today, if you see the scenario in India and all over the world, boys from PGI are doing the best. Because PGI emphasized that surgery is only 30–40%. Pre-operative planning, post-operative planning is an equally important thing. And I absolutely agree with you that we've done a great disservice by increasing we spread these jam too thin. There are too many DNP centers, too many centers giving training. Everybody can do a liver transplant on a rooftop also, am I right? Everybody is allowed. Our so simple, so easy that we are cutting corners. And I'm not one of those persons who believe my beliefs to be gospel truths. They are my interpretations, I may be wrong. I'm saying these things because I've made a lot of mistakes in my life. I've made big mistakes, but my only credit is I've learned from my mistakes. Some people keep making the same mistakes and call it experience, but that's a bad thing to do. I've made a lot of mistakes, and recently I was interviewed in some thing, and they asked me, what is your level of communication skills with your patient? I said, I'm not aware of it. I may interpret I'm a great guy, but my patients may not think the same. So one person who was in the audience, he said, I want to make a point. I said, the moderator said, go ahead. He said, 7 years back, me and my uncle were admitted in Medanta, and you used to come in the morning with big group of people, and you never talked to me properly, and you never talked to my uncle properly. So I said, right, that's right. I made mistakes. So what I'm saying is that we all make mistakes, we all do, but we got to learn from them. So I agree with you that we have to change our laws, we have to change our system, and we have to give a cerebral dimension to surgery and tell our juniors, cutting is not everything. You may be the world's best tailor. If the quality of cloth is not good, your results will never come. So to choose when to operate, when not to operate, I think it's a great thing.
So there was one famous saying by a French surgeon. Every surgeon has got a cemetery in his heart, where he goes time and again to pray. As you said, the mistakes. So how do you take about this? How do you think a surgeon, and there's this one thing that is second death syndrome. With every patient dying, part of a surgeon dies, a part of a medical profession dies. So how do you take this, and how the surgeon should contemplate to counter that?
You cannot counter that. The worst thing in life is when somebody is disturbed, you tell him, calm down, calm down. Never in the history of word by saying calming down, you calm down. It never happens. You have cut a vessel and you expect to calm down? It is stupid. You better react. You better throw your weight around because you have to stop the bleeding. I have killed some patients in my life. I confess openly I made mistakes. And trust me, it haunts me. Human beings do not like profits as much as we suffer from losses. In the share market, if I make 10,000 rupees, I don't care. But if I lose 1,000 rupees, I lose my sleep. Same way when I sleep at night, those patients whom I've killed, I see their faces very often. But then I tell myself that, did I do my best or not? Whenever confronted with a situation, you have to think, did I do my best or not? Now, what we have a policy is, we have a complication in our department, we call for help. Few weeks back, I was doing some surgery, I cut a blood vessel. The bleeding started with torrential bleeding. So I put a stitch in the superior mesenteric vein, the superior mesenteric vein got blocked. So my assistant, some assistants are very optimistic. They just want the surgery to finish fast. He said, okay, it's all done in children. If you even ligate the superior mesenteric vein, the collaterals form in patients do well. So those of you who are surgeons, remember a figure called 10. It's set in my mind. Whenever you do a procedure, think, how will it affect the patient in 10 hours, 10 days, 10 weeks, and 10 months, and 10 years. So I thought the bleeding is stopped for 10 hours, he'll be all right. But in 10 weeks, he's becoming gangrenous. So I called the vascular surgeon, he come and put a graft. So there was an observer watching me, he said, why could you not put a graft yourself? Why did you call a vascular surgeon? I said, I would have taken 1 hour, my vascular surgeon did 20 minutes. My ego is not important, it is the patient who matters. So I have made mistakes, but I've realized that calling for help, pre-operative planning, anticipating, thinking in advance, possibly helps in decreasing complications. But if you say they become zero, they will never become zero. You have to live. We all carry our cross in our heart. To say a surgeon is always successful, it means the sort of surgery we do, which is high end, there'll be complications. But you only console yourself saying, I did my best. I hope I've answered your question.
Hi, sir. So, you have been iconic in pancreatic surgery. So, if I go in your shoes, one thing which I would not be able to answer would be that whom does Dr. Adarsh Chowdhary go to when he thinks he has hit a roadblock? So, what beyond you, if you believe that this is where I stop? That's one. The second is talking of medical curriculum. I believe that there should be, the curriculum needs to be expanded. One, which we are not taught, is interpersonal relationship, our own relationships. That's one suffers. Even, the famous heart surgeon, he accepted this in one of the interviews with Christian Barnard. And then comes our relationship with the patient, psychology. I think we lack in that. And third comes in the psychology of money. We are not taught that how to earn, how to grow. So your thoughts on that?
One of the first things is we do not understand the difference between an illusion and a delusion. Illusions are not that harmful, delusions are harmful. If you want to know the difference, in a football match in 2005, when Ronaldo used to play for Manchester United, a kick came from the side in front of the goal post, and Ronaldo jumped into the air. And it looked like he was in the air still for about 1.2 seconds. If the ball came to him, he was suspended in air. Whether it's true or not, that's an illusion. But if you think you can wear Ronaldo's shorts and shoes, that's a delusion. So I am no icon. I'm just a student of this, but I was once asked, what is my greatest achievement? My greatest achievement is my students. They've done better than me. Rajesh Bhojwani is here. He was with us. He's a much better surgeon, much better human being, much better organizer than I am. So I that way feel very fulfilled. My students are not only skill strong, but they are value strong also. It's easy to learn skills, but to learn values is very important. So I've tried my best because my teachers gave me values. So I believe knowledge, wisdom, everything should be centrifugal. It should flow away from me than to me. Regarding your second question, I absolutely believe we are very insensitive people. We don't listen to patients. The moment the patient has come and says, I have pain in the right iliac fossa, we have stopped listening to him. My diagnosis is made. It is appendicitis. So we need to learn to be patient. Surgeons have what is called as a lot of belief in heuristics. Heuristics are mental shortcuts. Anybody who has pain in the iliac fossa, I don't want to listen to anything, it's gallstone disease. So that's what we do. We need to understand that patients don't know what a bright surgeon you are, what a great surgeon you are, how brilliant you are, what is your H index, how much you have published. They only want to know how much you care for them. And one of the best care is ability to listen to them, what they say. I also suffer from it. I also get impatient. But today my patience is just concealed impatience. I pretend that I'm listening to them. Maybe I'm not listening to them.
No, sir, apart from medicine, to be a whole human being, you have the other part also. You have a family, you have hobbies. So how do you manage that, and how does that help in achieving the success that you have? So was that helpful? Was that a hindrance? How helpful that was?
I'm no expert on this, and I don't think I've done full justice to my family. I'm publicly confessing I've failed as a family man. I don't think I did what I should have done. And I'm very guilty of that because I did not realize that these two things can go parallel. And I'm guilty that I didn't give my time, the time I should have given my family. So I have failed there, and I know it. And to say I now regret it's no point. What is gone is gone. What is done is done. So, but at least I'm aware of that. Regarding hobbies, I don't know because I don't want to sound condescending that I am some sort of motivational speaker or something. I don't know about that. Each of us as an individual, I believe I became a better human being, a better surgeon, a better scientist once I started reading. Books for me taught me a lot of things. So I think I became a better surgeon, a better human being, and I could be more empathetic towards my patients after reading, because people who have no other interest get obsessed. They go home and take their sorrows. They get into a lot of politics. They get a lot of backbiting, a lot of jealousy. If your interests are something else, then I don't think this matters. Today my interest is I want to do 1,000 push-ups in 1 week. That's my greatest thing. Rather than seeing how many patients is my colleague doing, how many surgeries doing, I don't care. I have to meet my targets. I think, I don't want to prophesize, I don't want to say, but that's what I believe. We all need to cultivate some sort of a hobby to make us able to express ourselves better in society.
We have Dr. Atul Kapoor with us, and
yeah, good afternoon, and very nice to hear amongst us a very passionate surgeon and widely experienced also. I would just give 1 or 2 comments first. See, whenever we talk about medical profession and its status and future, it always ends up with a kind of criticism that we don't have iconic teachers, our system has gone down, our curriculum has gone bad. It may be true, but these suggestions and awareness are non-productive, to the sense that most of us who are in this audience, we don't have the ability to change these systems. These are, in our Indian setups, a die-hard kind of situations, and we can only feel sad about it. So what we can do with the kind of experience and sensitivities which you have just now expressed, we in the private sector, as most of us are, or even in the government sector, I think we should develop the habit of trying to, inculcate systems in our departments, in our hospitals, where we have, a kind of a robust mechanism. For example, I fail to see people who have complete data in their setups, in their departments. There are no internal audits. Most of the physicians, which include surgeons and radiologists and pathologists, we live in, kind of isolated islands. We don't share our data. We don't have interactive mechanisms. So as a result of which, we get the kind of vision after traveling a journey of 2-3 decades in this profession, that is it really all about money and settling down for oneself, or is it a true profession? So I think these are the things which practically, if you try to spread in meetings, try to stimulate young and old patients, people, I do better.
I absolutely agree with what you say. It's a very interesting phenomenon with us. We don't like to say, we actually lack passion. We actually lack passion. When I go to meetings and do a workshop, many young doctors come to me and say, "Sir, I want to visit your center." And that interest sustains only for 1 or 2 hours. Nobody ever gets back. We by nature are not systematic. I actually think. We are. You see a patient, you ask him, when was your surgery done? So wife says it was done in 2015. The husband says, no, 2015, Papu got married. Okay. Then 2017, no, 2017 the roof got burnt. So they remember everything except the date of surgery. Because we as Indians have never maintained data. We are not trained. Our gurus never wrote anything because it was word of mouth. Why did Ayurveda not grow? Because it was not written. Whereas you see a small country like Italy, which may be smaller population than Punjab, produces so many papers. I'm not saying producing papers is the index. What have we contributed to the world literature in science, in medicine? Nothing. Very little. Very little. Because by nature, we are not scientific. It is not a part of our system. So my aim is that I always tell everybody, I agree with you, just maintain data. Just maintain data and try to publish something. It might sound that very condescending, but actually we have done very little. We could have been capable of much more. But that's the way we are. We are not taught. When I was in PGI, there was a class of statistics. I feel PGI was so good that they thought statistics is important. But they never told us why is it important. So all of us passed the exam just by looking left, right and center, and we passed. And today, if you ask me one big regret of my life, I wish I knew statistics. So there is a term called as, in teaching, called as elementitis and aboutitis. Aboutitis means that most of us know about something a little bit. Deep down we don't know. And elementitis is that we have never taught the purpose of what we are being taught. If I was told in PGI that statistics is important, because subsequently when you do research, you can write papers, you can maintain your data, it will take you somewhere, I would have paid more interest. I thought it's a chore, I have to finish it, pass the exam, I got MS degree. So that's the sad part of our lives.
Any questions from back?
It's always a pleasure to listen to Dr. Chowdhary, but I want to add one point here. We are talking about the data and the research. Here is a person who, regarding international publications and research, is unmatchable both in the private and the government sector. I have remained in medical work for so many years, but in private sector, to have so many publications, there were several papers jointly with me as well, and he has been invited to be honored in states, and latest, I don't know which association, Cancer Association has invited in Japan or China, to invite just based on his research on cancer. So, we are all
Sir, but he's a case report.
Yes.
There's only one.
Yes.
In a population of thousands, you should be able to say there are 50. That's the sad part. That's the sad part. There are so many of us.
Anyway, we are proud of such a person. At least one, there is one. Although we are associated with it more than once. Well, the second thing we have been talking about this curriculum, as he was saying, can we put medical ethics in curriculum and teach our students how to maintain the ethics once you become a doctor? If I start narrating what's happening in the professions, I would myself be, ashamed. There's so many things which I can't quote, but so the medical ethics is an important aspect. I would not mention anything, but I am observing, he is observing, you are observing.
Can I say something about it?
Yes, sure.
Please sit down. Do we have to be taught ethics? Just by putting in curriculum, will we learn ethics? You ask yourself a question. If you say honesty is the best policy, it's a stupid statement. Why should it be a policy? It's a natural thing. Just by incorporating ethics, we don't learn ethics. We are role models. We do things. The problem with most of us is we have two sets of rules. One for me, one for others. This is the sad part. So ethics is something which the voice comes from inside. I agree with you, but I don't think curriculum is there. In the audience is Dr. Y.K. Chawla, who's been himself a leader, who knows. He will agree with me that the institute provides all the facilities. Dr. Chawla, I wanted to say something. Dr. Chawla, the institute does so much.
I think that's a very valid point raised. Ethics needs to be discussed more often. Maybe in the curriculum it may not help much, but certainly you have to be role models for the youngsters, which probably is not happening. Even we have probably failed in being role models for the students. So you have a very valid point. Curriculum could be included of ethics, but that has to be practiced.
Yeah, please go ahead. Please.
Good afternoon. I really want to congratulate the organizers for having this session here. Dr. Chowdhary, it's been a pleasure to listen to you. Usually we attend conferences and they're jam-packed, 15 minutes, 15 minutes, 15 minutes, 15 minutes, we have this session, we have this session, we have this session. But to be able to discuss such things is actually something, I think it's the need of the hour. As far as the question of medical ethics being included in the curriculum, you're right when you say that ethics does not need to be taught, right? It comes from inside. But there are many times when such things are being discussed, and when in the rat race or the race of everyday life, sometimes these things get ignored or neglected or maybe forgotten. And if someone as a role model, as for example you listening to you, or maybe somebody just happens to mention those things, it does make a difference in somebody's life. I've been in a school where nuns used to teach us, so we used to have a period on moral science every week. At that age, I used to think it's such a waste of time. Why do they have to put this period in that? But now, when I think about it and when I remember and I recall all those things that I was taught at that time, does make a lot of difference. And it has really helped me in my life now. And I'm sure if at that age of growing up, when you're taught, as you said, by rote, remember anatomy relation, we don't even remember. At that time, we are learning. We don't understand why it is important to remember the relations. I'm a radiologist now. Now I know the importance of what is behind the duodenum, what is to the left, what is to the right. At that time, I never knew about it, right? Even that really jam-packed curriculum, if we do have a lecture or a period of medical ethics in which little things are discussed, maybe just as Dr. Amitabh said, interpersonal relationships, patient-doctor relationships, little things, just discuss, sometimes stay in the mind and maybe help later.
You have a point.
Good afternoon, sir. So I have two questions. Like we were discussing medical curriculum. As a medical teacher, first I want to know that every year we have to give thesis topic or the research topic. How far do you think that, what sort of research topic to be given to the PhDs, or it is just a hoax?
It's a hoax.
So should we continue with this hoax then?
You see, we are discussing, these are useless topics.
Right.
We have no teeth. We are wasting time. We are not policy formers.
Sure.
So this is a wastage of time. Ethics should be included. We are discussing issues, what we can do.
Right.
Let's discuss what we can do. It's in the hand. There is no medical person sitting here. So we should discuss what is in our hands.
And the second thing, sir, I wanted to ask that, like every patient teaches us a new thing. And over the time, surgery has progressed from open to now the robotics. When should a surgeon decide that he has to continue with the same technique or enter a new technique, or is it just a rat race that you have to learn every time a new thing comes in the market?
First, on the lighter side, even if you win a rat race, you still remain a rat. So to say that, oh, robotic is very good, open is very good, laparoscopy is very good, it's a very difficult question to answer. And there are no answers also to this. So long as you can do a procedure well, in a scientific way, be honest to yourself, you should do whatever you want. To say that, you know, I learned this very late in my life, that to accept another person's point of view as a point of view. I used to be against laparoscopic surgery many years back, and I told one person, Murray Brennan was a very famous surgeon in Sloan Kettering, a man I respect a lot. So I met him, I said, are you doing laparoscopy, Vipul? He said, I don't do. He said, do you do? I said, I don't do. He said, why don't you do? I said, I don't think it works. He said, that's not true. Maybe it does not work in your and mine hands, it might work in somebody else's hands. To say that this is best, you have to accept the policy of dualism. There are multiple ways to reach God. You can do a good cancer operation, open, laparoscopic or robotic. It doesn't make a difference so long as you do it well. That's my answer to your question. Yeah.
Dr. Bhojwani.
Sir.
Did you hear me praise you, or were you in the hall?
No. No. So, I'm not only your student, I'm your ardent follower for so many years. You're a role model also. I've been watching you for so many years. It's been almost about 25, 30 years. I want to understand from you, what is the key to stay relevant in this world as a surgeon, with the paradigm changing so often, technology, facilities, market, pressures, science, research, everything is changing so fast. What's the key to stay relevant as you've been all the time?
First of all, in all humility, I don't think I'm very relevant, but I think we all need to have a degree of restlessness. I am a great student of curiosity. I think so long as you remain curious, one thing leads to another. He said a very valid thing. I think if you audit your own data, a lot of learning comes from it. Am I right? When you eyeball your own data, sometimes I realize I made the patients much worse after surgery than they were before surgery. I think the key to life is not in getting answers, it's putting the right questions. Look at your own career. Look at your own career. How you started and where you landed. It's essentially, I think, all people who are successful have one quality in them. They believe that the locus of control is me. Not that when I failed, my father didn't support, my this support. When you believe I am responsible for myself. So I go to a meeting, there are people who hate me, who want to always prove me wrong. When I give a talk on pancreatic cancer, I know they'll be there. They'll ask a question which will make me feel small, so I read everything before that. Because I know they want to pull me down. So they are your biggest supporters, people who are your criticism, who give you think. So you have to protect yourself, and to protect yourself, the only power is the power of knowledge. What else do we have? We have nothing. The power of knowledge. So long as you keep reading, so long as you keep yourself well abreast of things, I think you stay relevant. I hope I've answered your question. But your question had the answer hidden in it. You already know the answer to this.
Very good morning, sir. You would have treated many complicated patients who would have landed up with complications done by some other surgeons. So how far do you go in safeguarding the primary surgeon, as it is very easy to be wise in retrospect?
It's a 100% protecting the primary surgeon. But what happens is the primary surgeons themselves harm so much many times that we cannot protect them. What I mean is, today's patient is very awake and alert. I've been involved in many medical legal cases. I must have appeared in 18 court cases of violent injury against the primary surgeon. And invariably, the surgeon who informed the patient that something has happened never had any punishment. Patients, at that time it's very difficult, but at that time patients feel bad, but the judge, the judiciary supports, because we say that 0.2%, 0.3% incidence of injury is known. So it can happen. But when you don't tell the patient tells something else, that's when a problem. But we make all the effort to protect the primary surgeon, because I as a surgeon know I myself create so many complications. So we always protect the identity of a surgeon. But a surgeon also has a great responsibility that he should conduct himself in a proper way when a complication occurs.
One of the questions, a little bit of pushback to what you just said and discussed. I think we discussed a lot of things with a feeling of helplessness. So we can't change the system, we can't do this, we can't do that. I think we have a little bit more agency than we think it's possible. You know, Maya Angelou said that the biggest risk is not in recognizing your agency and thinking that you have less, you can do less than you can. I suspect that a lot of us can do, because we may not be making policy in the
that I agree. So I agree. Yeah. Because progress is not one big change, it's a series of small changes. If we change ourselves, things will happen, but I agree. I agree.
Good afternoon, everyone. I know I may not be a member here, but I would like to highlight here that new medical education has started putting communication as a part of orientation program also, and AdCom module has been brought up by NMC, and they are teaching the students, medical students, undergraduates about the legal implications and ethics also. Great. It has started coming up. Let's hope it turns out to be good.
That's good news, that's good.
Sir, one last question from my side. What do you think about the medical legal issues which are happening, and now do you think we've started practicing more of a defensive surgery or a defensive medicine, and what are your views on that?
Yes, we definitely are practicing defensive medicine, at least we are. We are in a very high litigious society. We practice a lot of defensive medicine, but I myself have had many problems, issues, and in 100% of them, the issue was a lack of communication or a miscommunication. Because there are so many people involved in communication, I think, like the lady just said, we need to communicate in a much better way. When I was young, hospitals didn't have a counseling room. Not all hospitals have a counseling room. It cannot be more. There are two things which are important today, I realize. One is counseling, second is a consent form. If you want to save yourself medico-legally, counseling and your consent forms have to be absolutely flawless, because the court only sees two things. If you inform them beforehand and your consent form is okay, you can get away with nearly everything. Unfortunately, what happens is our counseling is very sketchy. We should formulate a way that I will tell 5 things in this counseling. Have the 5 things been answered? So if you have those 5 things answered, that you tell the patients what is the need for surgery, what are the side effects, is there any alternative thing available, any other procedures there, and last thing you must ask a patient is there any question that you want to ask? So once you give them option, I believe it's all because of lack of communication. We are so busy that we forget that we have to talk, and patients sometimes irritate you, they ask stupid questions, but what to do? We have to do that. That's my belief in that.
Thank you, sir. Thank you.
Thank you, sir, for sharing your your words of wisdom with us, and we believe that the lessons learned today shall stay with us throughout our lives. Now I request Dr. Ravinder Singh Malhotra and Dr. J.S. Sidhu to felicitate our esteemed speaker. All candidates of